Good evening, everyone. Myself, Dr. Pallavi Waghalkar. I'm anesthesia professor. Today, we have joined to discuss about the anesthesia considerations in the maxillofacial trauma for surgery. Now, maxillofacial trauma presents significant challenges for anesthesiologists and the trauma team also due to the critical involvement of the airway itself. So managing these complex injuries, they will require a specialized knowledge about the facial anatomy, then understanding of the injury patterns, then expertise, advanced airway management technique also. So this is the basically article in the February 2025 by World Federation of Societies of Anesthesiologists, which is the more which I have referred to, and they have discussed about the checklist for the airway management. So let's go through this article. So first of all, patients with maxillofacial trauma present with a unique airway management challenges for anesthetists in emergency, in the operative room for the reconstructive surgeries, and also post-operatively in ICU, in a ward in ICU, we have to be facing these patients. What are the anesthesia consideration basically in this? Because the form of injury and the possible involvement of basically airway. Then the bag wall mask itself can be difficult. Also the endotracheal intubation. All these maxillofacial trauma patients, there will be cervical spine involvement. So again, that will be difficult for us. Then patient might be full stomach. So there is risk of aspiration of gastric contents. And also the face is highly vascular, so there can be a bleeding that may, occlude our view in an oral cavity. These are the, considered to be airway. So basically, as we see, there will be for a oropharyngeal obstruction because there can be displaced tooth, bone, soft tissue, debris. The mandible fracture, they will be altering the floor of mouth anatomy. There can be large tongue because of the injury and swelling and the edema. There can be nasopharyngeal obstruction because of the base of skull fractures. There will be fractured maxilla, which will be displaced posteriorly, or there will be edema again. Also, there is aspiration risk because of lack of NPO status. There can be accumulated blood and the air in the stomach, which patient has swallowed. There might be increased secretions because of the trauma. There can be active hemorrhage because of highly vascular regions or trauma causing DIC later on and superficial arteries. The larynx and this anatomy can be disturbed, so the tracheal ring fracture itself can be there. There can be airway edema down, or there will be false lumen formation if there is more handling of airway. Also RT, if we are putting, then there will be false lumen formation. Poor head positioning because of cervical spine involvement, or a limited neck extension because of trauma, or patient will have a limited mouth opening. So all this in together, it will be a difficult airway for anesthesiologist. Fractures of the facial bones commonly are the mandibular fractures, while the nasal fractures would be around about 20%. The trauma which will lead to maxillofacial region will cause bony structural damage. It will cause soft tissues damage with the skin and the gums damage. Also the eyes, facial nerve and the glands can be injured. So the facial anatomy we have to consider when we are talking about the management of this patient. So the anatomical classification of important maxillofacial bones, if you see, the upper face, that is 1/3 is by the cranium. And so the fracture classification, if we see, the upper face fractures, there will be frontal bone and sinuses involved where 33% dural tears will be there. In mid-facial fractures, there will be nasal, orbital, nasoethymoid, zygomatic and maxillary fractures will be there. And lower fractures are mandibular, which can be unilateral, bilateral or comminuted. And there will be panfacial fractures also, which involve all the three facial segments. Now, each fracture pattern carries a specific risk for airway compromise, with the mandibular and panfacial fractures presenting the highest risk for the airway obstruction. Of course, we know the maxillary fractures has been classified by Leafort's. So the Leafort 1 is the horizontal maxillary fracture, which is floating palate, or Lefort 2 is pyramidal fracture, where it's a floating maxilla, and Lefort 3 is a craniofacial junction. This is basically a floating face. So the combination of these fracture patterns also occur in frequently in clinical practices. So if we see the mechanisms of a maxillofacial injury, this can be road traffic accidents, there can be a blunt trauma, there can be a penetrating injury, and there can be the, excuse me, the explosive injuries. So blunt trauma basically causes will be road traffic accidents or a interpersonal violence, or patient has falls. Now, blunt trauma injury pattern will be, there will be less of a soft tissue damage than a penetrating trauma whenever there is a penetrating trauma. There is a predictable linear fracture pattern of maxilla and mandible in a blunt trauma. So, blunt trauma will be often associated with the dental damages, often associated with the cervical spine and the head injuries. So, what are the anesthesia concerns in the blunt trauma? That can lead to edema and airway obstruction, or it can lead to restricted mouth opening and difficult magval mask ventilation because the face might be swollen because of the trauma. The second type of mechanism of injury will be penetrating trauma, like because of the projectiles, gunshots, or stabbing. So that injury pattern will be depending upon the weapon caliber as well as the mass and the velocity with which the projectile has happened. So there can be lacerations and contusions with low velocity, or there will be cavitations and stress effect with a high velocity injury. There will be comminuted fractures, and large explosive exit wounds are associated with the tumbling and yawing of the high velocity projectiles. So what are the anesthesia concern in penetrating trauma? There will be rapid airway obstruction directly related to the velocity of missile. So there is no time in these cases of injuries. The injury may require a complex reconstructive surgeries in future. And in cases of explosions, the primary injury will be because of mass movement of the air. The secondary will be the flying debris in cases of explosive. And the tertiary will be victims might be thrown through the air, and that will lead to airway trauma. So here the injury patterns in the primary blast injuries will be typically involving the damage to the air-filled structures like ears or paranasal sinuses. Or secondary blast injuries similar to the penetrating injury. Tertiary blast injuries typically involve the multiple injuries, often complicated by gross contamination. And complex, extensive injury patterns in these labs is invariably involving the airway. So these are all complex patterns of the maxillofacial injuries. In a frontal bone fractures, the isolated fractures typically do not cause more direct impact on the airway. However, these frontal bone fractures can lead to complications like pneumocephalus or intracranial hemorrhage. If there is an excessive back-wall mask ventilation in these patients, it can lead to pneumocephalus. High energy trauma increases the risk of concurrent anterior skull base fractures or posing the risk of intracranial penetration whenever we are inserting the nasal tube. So we have to be careful in these cases where there is a nasal intubation or RT insertion. In a mid-face fracture, depending upon the fracture's location and severity, which is potentially leading to the airway obstruction or bleeding can be there. There might be subcutaneous emphysema in a mid-face fractures. Epistaxis will be making your vision difficult. Because of the nose fracture, there will be difficult mask holding, difficult back-wall mask ventilation. In a nasoorbital ethmoid fractures, they basically in isolation or Lefort's or a panfacial fracture. Again, there will be intracranial extension through the nasal passages will be there. In a zygomatic arch patch, there will be restricted mouth opening, which will be not be improving with the general anesthesia or neuromuscular blockage. Because in general, maxillofacial, some minimal injuries, because of the pain, basically, patient is not opening the mouth, the restricted mouth opening, which can be relieved after your analgesia or GA. But in cases of zygomatic arch fractures, it will not be relieved. The mandibular fractures and the airway impact. Now, the mandibular fractures can be simple fractures, unilateral, single breaks with the minimal. This is the left side of the screen, limited airway impact. While there will be bilateral fractures, there is a bucket handle fractures, which will cause the tongue to fall backward, and there is high risk of obstruction. this cause loose teeth will be there because of the